Good morning, everybody. I thank the organizers, especially Ira, for giving me this opportunity to be here on a Sunday morning. And I hope I really do justice to this topic of cytokines and infections. To begin with, I have divided my talk into two aspects. One which deals with the basics of cytokines, as Kushnuma already said that we've forgotten most of it. And the second which says about its implications in various diseases. So what are cytokines? They are basically polypeptides which are secreted by cells of the innate and the adaptive immune system in response to microbes or antigens, and then they act by their specific membrane target receptors on cells, on the target cells, giving new functions or proliferation of the cells. They are named according to their origin of cell as interleukins, which are produced by the leukocytes, lymphokines produced by the lymphocytes, monokines by the monocytes. We have the interferons, the colony stimulating factors, and the chemokines which promote chemotaxis. Now the action may be either autocrine, acting on the cell which produces it, paracrine, which acts on the nearby cell, or endocrine, where it gets circulated by the bloodstream to various sites. Now the initial concept of one cell, one cytokine, one target cell no longer holds true. So here, in the next few slides, we'll see how one cytokine can act on different cells. They are potent in very minute quantities, and it's a self-limited event. It's a very transient action which the cytokines have. They can act by pleiotropy, where one cytokine may act on different cells, or redundancy, where many cytokines act on one cell. They can have a synergistic action with the other cytokines, or may have an antagonistic effect. This is a pictorial representation of what I have said, which is showing your IL-4 acting on different types of cells, whereas the next one where 3 cytokines are acting on one cell, and IL-4 plus IL-5 showing a synergistic action causing a switch to IgE, whereas interferon gamma causing a block of IL-4 and preventing the switch to IgE. So basically these cytokines, they act on the membrane, on the target receptors, and they act as intracellular messengers and cause new functions or proliferation of the target cells. They are compared to growth factors because both act as cellular survival factors and prevent apoptosis. But the difference is that the cytokines are basically immunomodulatory proteins, whereas the growth factors act on the non-immune cells. There are a lot of assays to detect the cytokines, like the ELISA or the RT-PCR, which detects the presence of mRNA encoding specific cytokines. The cytokines can exist either in the soluble form or in a membrane-bound form, and this switch between the two of them is an important immunoregulatory event. Now, as we know that the innate immunity basically consists of the epithelial barrier, the phagocytes, the complement, and the NK cells, whereas the adaptive immune system consists of the T and the B lymphocytes. So the phagocytes, the mononuclear phagocytes, and the neutrophils are the first to come into action whenever there is an attack on the body. And they do this by forming invaginations called pseudopodia. The macrophages get activated, they form the pseudopodia, form a phagosome, which then forms a lysosome, which digests the bacterial products, and the digestion enzymes are released by the cell. So the mononuclear phagocytes are the principal source of cytokines of innate immunity, and they secrete tumor necrosis factor, IL-1, IL-12, type 1 interferons, IL-15, IL-18. The NK cells basically act by secreting interferon gamma, which acts on the macrophages to digest the ingested microbes. The adaptive immune system also, the T cells respond by secreting cytokines, and that's how the T helper cells mediate their function. Now the adaptive immune system produces a Th1, Th2, T17, and a Treg response, which is shown here that a Th1 response secretes interferon gamma, whereas a Th2 gives IL-4, IL-5, IL-13. A Th17 gives a Th17 response. Now, when a naive T cell is presented with an antigen-presenting cell, as you can see in the slide here, what happens is that the naive T cell gets activated. There is a secretion by the macrophage of IL-12 and IL-18, which acts on the naive T cell and converts it into a CD4 helper T cell, which then secretes, giving a Th1 response, which then secretes interferon gamma, which acts back on the macrophage, and that causes digestion of the ingested microbe. It also gives a Th2 response, where IL-4, IL-5, IL-10, and IL-13 are secreted, and that causes a stimulation of the B cells. So that is how basically the adaptive immune system works. So the function of these cytokines are basically divided: those that act during the innate system, those that regulate the adaptive system, and those that stimulate hematopoiesis. So the innate system basically acts by activating the endothelial cells and the neutrophils. The third variety, that is the hemopoietic system, they induce the bone marrow stromal cells, and there is a secretion of stem cell factor, IL-3, IL-7, and GM-CSF. When we look at the biologic actions, the biologic actions are also divided according to the cells of the innate system, the cells of the adaptive system, and those that stimulate the hematopoiesis. So initially, the adaptive immune system produces pro-inflammatory cytokines like IL-1, IL-6, and tumor necrosis factor, along with the other array of cytokines. So whenever there is an infection, the adaptive immune system comes into action, and these inflammatory cytokines act on the endothelial cells, making them leaky to fluids and causing a chemotaxis of the neutrophils at the site of infection, which is shown in this slide. The tumor necrosis factor has different activities at different concentrations. In low concentration, it acts on the similar to IL-1, where it causes leukocyte activation and endothelial activation. In moderate quantities, it causes fever. It also acts on the liver, causing release of acute phase proteins and stimulates the bone marrow. Whereas in high quantities, it causes septic shock, thrombus, and hypoglycemia. Next, we come to the chemokines. The chemokines basically cause chemotaxis, and they act on the primary lymphoid organs, causing the migration to the secondary lymphoid organs, and then to the blood, and then to the tissues. So the cells reach the site of infection. Now, when we come to the chemokines, they are basically divided into families based on the number and the location of the N-terminal cysteine residues. This is how this is a pictorial representation of what I've talked till now. Next, we come to the type 1 interferons, which are basically of two types, alpha and beta. Alpha by the mononuclear phagocytes, and beta secreted by the fibroblasts. Their basic action is to inhibit viral replication, increase the expression of class 1 MHC molecules, and cause a Th1 response. So when there is a viral infection on a cell, the type 1 interferon gets activated, and the virally infected cell secretes type 1 interferon, interferon alpha, which acts on the neighboring cell and prevents the viral replication, and thus blocks further propagation of the virus in the body. IL-12 is also a very important cytokine of the innate immune system, where IL-12, when is secreted, when a microbe activates the macrophages, the antigen-presenting cells, it secretes IL-12. And this IL-12 then acts on the NK cells, the CD4 T helper cells, and the cytotoxic CD8 cells. The NK cells and the CD4 T cells secrete interferon gamma, which acts on the macrophages to digest the ingested microbes, to phagocytose the ingested microbes. So the IL-12 interferon gamma loop is a very important pathway which prevents the intracellular infection against the intracellular pathogens like Mycobacterium tuberculosis salmonella. It also acts on the CD8 cytotoxic cells and causes increased cytolytic activity. So this is basically what I've talked, that basically in a bacterial or a infection, initially there is a response by TNF and IL-1 secretion, which acts on the neutrophils and the endothelial cells, and later by IL-12, which causes interferon gamma secretion, which acts on which causes phagocytosis by macrophage activation. This is a repetition that a Th1, Th2 response and a Treg response is by the adaptive immune system. This slide is also a repetition of what I have just said. Now, this slide is showing how a T cell, which is latent, is stimulated by an IL-2 secretion, which is causing a proliferation of the T cells and helping out in infection. So basically these Th1, Th2 responses are very important for our body, where if there is a skew towards a Th1 response, there is going to be an excess of IL-12, interferon gamma in our body. And that is the basis of all autoimmune diseases. So whenever there is an IL-12, interferon gamma, TNF alpha excess secretion, we are prone to autoimmune diseases. Whereas in conditions where there is a Th2 response, there is an IL-12 interferon gamma loop deficiency, which gives rise to infections with intracellular organisms like Mycobacterium tuberculosis, Cryptococcus neoformans, Salmonella, etc. In SLE, there is an increased IL-10 production because of an exaggerated Th2 response, and so we have systemic lupus erythematosus. Allergy, atopy, is also because of a Th2 response. In HIV, we have a worsening IL-12 deficiency, and which worsens the disease. Whereas for tumor growth to be inhibited, there has to be an IL-2 which is required. And if IL-2 is deficient and IL-10 and IL-1B6 is increased, then we get tumor growth. Now we come to case scenarios. Now this is a case which I have seen at Vadia Children. This was Sneha, an 8-month-old female child born of a non-consanguineous marriage, who had come with excessive crying at 5 months of age and noticed to have a fluctuant left axillary swelling. In spite of oral medications, the swelling was enlarging, had become erythematous over the next 2-3 days, and started discharging a reddish discharge. She was brought to Somaiya Hospital, where an excision biopsy was done and intra and extracellular AFB was seen. She was immunized till date, BCG received on day 4, and diet and development was normal. This is how the swelling was when the child presented to us. She was managed at Somaiya with AKT, but with no response, she was sent to us. This is the pathology slide which is showing the acid-fast bacilli in this child. On examination, she was well grown with a birth weight of 3.75 and 8.5 was the current weight. The BCG marks showed a pustule without pus, without scarring. There were bilateral cervical and right inguinal nodes 1 centimeter each. Left axillary node showed a reddish erythema with sinus formation. She had hepatosplenomegaly. Her CBC was normal. CT scan had shown necrotic lymph nodes in the cervical, mediastinal and left axillary region, and her HIV and HbSAg was negative. She was suspected to have IL-12 interferon gamma loop defect. She was basically a case of BCGosis because all this has happened post-BCG immunization. So she was suspected to be a BCGosis and workup was sent to France. We don't have the facilities here, and her diagnosis was confirmed. So this IL-12 interferon has come into effect here. This child, when infected with Mycobacterium tuberculosis, has not given a response by IL-12 secretion or by interferon gamma secretion, where IL-12 would have induced the NK cells and the CD4 T cells to secrete interferon gamma, which would have caused phagocytosis by the macrophages of the Mycobacterium tuberculosis. But unfortunately, in this girl, this has not happened. Here, it's the same thing which is shown again by another pictorial representation, how the T cells, when activated by the macrophages, secrete interferon gamma, which act on the macrophages again. Next was a 6-year-old child hailing from Bihar who had presented with fever since 2 months, hepatosplenomegaly, pancytopenia and weight loss. The CBC was suggestive of pancytopenia. The peripheral smear showed no abnormal cells, and the bone marrow showed LD bodies. Now this is the LD bodies which are seen in the bone marrow of this child, and this is a closer view of the same thing. Now why has this child suffered from leishmaniasis? This is basically because the TNF response and the interferon gamma response in this child have not taken place. Had this child had the proper cytokine secreted, this child would not have suffered from leishmaniasis. So absence of these cytokines leads to the persistence of leishmania in the body, giving rise to leishmaniasis. And interferon gamma can be used as a treatment in the propagation, in the inhibition of propagation of leishmaniasis. This is a child, 3-year-old with falciparum malaria, treated with antimalarials, referred to us because the child still has the pancytopenia persisting and not showing a response to all the antimalarials given. The peripheral smear on examination is showing hemophagocytosis. And the bone marrow done in this child is also showing hemophagocytosis. This is happening a lot of times where we see hemophagocytosis occurring with a lot of infections like malaria, dengue, viral infections, salmonella. So we are seeing a lot of even with leukemias. So this is what the here you can see the macrophages, a lot of nuclei inside one cell, and even an RBC has been ingested by the cell. And why does hemophagocytosis occur? It occurs because of there is an excessive activation, and there is a hypercytokinemia, and there is an excessive activation of the antigen presenting cells like the macrophages, histiocytes, and the CD8 T cells, because of which there is a cytokine storm happening. This is what is happening, and because of which a whole gamut of cytokines are being released into the body, each one having its own effect. So this uncontrolled activation is giving rise to a cytokine storm. Now the IL-1 is responsible for the fever which happens in hemophagocytosis, TNF-alpha for the hepatic injury and the coagulopathy. It also causes inhibition of the lipoprotein lipase, giving rise to hypertriglyceridemia, and interferon gamma causes macrophage activation, hemophagocytosis, cytopenias, and muscle wasting. There is also an increased secretion of soluble IL-2 receptor alpha and beta-2 microglobulin levels. Serum ferritin rises tremendously in children with hemophagocytosis, and that occurs because of the macrophage activation that is occurring. There are proposed HLH diagnostic criteria which have been revised in 2009, where they have said that at least 3 of the 4 criteria of fever, splenomegaly, cytopenia, and hepatitis are required, and 1 of the 4 of hemophagocytosis, increased ferritin, soluble IL-2 receptor, and decreased or absent NK cell function is required. The supportive criteria are hypertriglyceridemia, hyperfibrinogenemia, hyponatremia, and 5 of these 8 criteria, if present, you can diagnose hemophagocytosis, though you may not have hemophagocytes in the peripheral smear or in the bone marrow. This is another case. Unfortunately, I don't have the pictures of this child. This child had come in 2006 at Vadia. The 3-year, 10-month-old male child, firstborn of a 3rd-degree consanguineous marriage, who was admitted on 24th January for fever, cough, and dyspnea for 10 days. This child had similar complaints since 7 months of age, for which he was hospitalized 3 times. On physical examination, he was febrile with bilateral pitting edema, bilateral crepitations on lung auscultation, and a maculopapular rash all over the abdomen. The liver was 6 and the spleen of 20 centimeters. The hemoglobin was normal except for thrombocytopenia and an increased retic of 7%, and the Coombs was negative. The IgE was normal and HIV was negative. The chest X-ray showed paratracheal lymphadenopathy, and lung parenchymal changes were suggestive of interstitial edema. The lung biopsy done on 11th February showed interstitial lung disease consistent with desquamating interstitial pneumonia. The bone marrow was hypercellular with trilineage hyperplasia. ANA was negative, nothing abnormal seen. Ultrafast CT of the thorax and abdomen had shown bilateral pleural effusion, right more than the left, basal consolidation bilaterally, enlarged paratracheal node, pericardial effusion, and gross hepatosplenomegaly, nothing else. And pleural fluid examination was normal. On second admission in June 2006, that was 5 months after the first admission, the weight was 14, height was 96. There was a left axillary lymph node 1 by 1 centimeter. Liver and spleen had regressed from the previous admission this time. The child's immunoglobulin showed 0 levels of IgG and IgA, and in IgM of 900 milligrams per DL. Lymphocyte subset analysis showed an ALC of 1740, B cells were low. CD4 cells had increased, the CD8 cells were low, and HIV was negative. Looking at this picture, an IgM, hyper-IgM syndrome was thought of in this child because the immunoglobulin G and A levels are completely absent. Now what happens in hyper-IgM syndrome? The T cells get activated, the T cells, they bind with the B cells through the CD40 ligand. And if the T cells which have the CD40 ligand or CD154 if they do not activate the B cells, the isotype switching from IgM to the other immunoglobulins doesn't occur. So there is a deficiency of IgG, IgA, and IgE, which then keeps the patient exposed to the extracellular pathogens. At the same time, the T cell does not secrete the cytokines like interferon gamma.
You have 2 more minutes
left. And IL-2.
2 more minutes left.
Yeah. IL-2 and interferon gamma. And these cytokines, because they don't get secreted, the child is prone to intracellular pathogens. So that's why the child gets exposed to extracellular and intracellular organisms. And this is how a child with a hyper IgM will present with repeated infections. So cytokines are basically used in treating various human diseases like erythropoietin, as we all know, which we use. GM-CSF is used in chemotherapy resistant to infectious diseases. Interferon beta in multiple sclerosis, alpha in hepatitis C virus and AML, and TNF inhibitors are used in treating rheumatoid arthritis and Crohn's disease. So this is a short view of how the cytokines work in infections. Thank you.